Okay. Hi everybody. Now this is going to be, yay, our last neuro lecture. This neuro's gotten a little bit long, but we've got one more to do. And this is chapter 70 in your Lippincott book. So in this chapter we're going to talk about the some of the cancers that can occur in the neurosystem, and then some of the degenerative disorders. And there's not a lot to talk about here, so I'm just going to point out a couple things. This should be a relatively short session. I do need you to understand some of the words. It's important to understand medical words so when you're talking to other people within the medical community, you sound like you know what you're talking about. So the things I wanted to point out, kind of look at the glossary with me on page 2052. This first word, akathisia, that is like somebody who's just constantly moving. You may have heard of like restless leg syndrome, where their legs are constantly moving. That's the medical term for restlessness, constantly moving, but more than just like more than somebody who just has ADD. It's a motor neurological need to constantly be in motion. And just the opposite of that is bradykinesia. Bradykinesia is very slow movements. People with Parkinson's, that we'll talk about later, end up having bradykinesia. All their movements are very slow. And it's a neurological slowness, not just a result of aging. Chorea is the next one down. Chorea is real, like, rapid, jerky, very unpurposeful movements, and that's often associated with some brain tumors, some neurological problems, and specifically Huntington's disease, which is also known as Huntington's chorea. Because it's just very unusual movements, and it's frustrating for somebody because cognitively they're okay, but they can't control their limbs. Their limbs are just kind of going all over the place. That's chorea. Dementia, you know what dementia is. Dyskinesia. Dyskinesia is an impaired ability to execute voluntary movements. So, and we've talked a little bit about that, like we talked about like people who have some neurological disorders, specifically strokes, where they want to execute a certain voluntary movement. Like, I want to go, pick up this pen so I can write. They're unable to do that. Dyskinesia is like they want to get to, they know they want to get to the pen, but they kind of, they've got spatial problems. Their movements are not what they want it to be during voluntary movements. Dysphonia, we've talked about, is like a raspy, impaired voice. It has a lot to do with the laryngeal structures. Okay, the next one down, you have to know this. I'm sure you're going to get a question about this on NCLEX because it's in all the textbooks. It's rare, but it's significant enough that you do need to know this word, and it's pronounced, let me get this right, homonymous hemianopsia. Homonymous hemianopsia. And what that means is it is a deficit whereby half of each visual field is blind. And it's usually on the same like the opposite side of the lesion. So if there's a lesion on the left side of the brain, the blindness will occur in the right half of this eye and the right half of this eye. So they're only seeing out of like the left half of each eye, which makes vision very unusual and very difficult. So if you get a patient who has this disorder, homonymous hemianopsia, which is very hard to say, watch for things like if you set their tray down in front of them and they're just not eating some of the food, it might be that they can't see the food, or if they're not picking up their toothbrush or their toothpaste, they might not see it. So they have to be taught to scan with their head in order to be able to see everything that's in their visual field. So instead of just staring straight ahead, they might have to learn to start doing like this and training their eyes to catch the part that the blind part of their eyes aren't seeing. So not super common, but guaranteed you'll see it on a test. Micrographia, small tiny writing, often following a stroke. Neurodegenerative neurodegenerative disease. We're going to talk about some of those like Parkinson's, Huntington chorias, some things like that. Nystagmus is just involuntary movement of the eye. That's super common. Palpal edema, edema in the optic nerves. Now, paresthesia. You should be familiar with this by now, but a paresthesia is a numbness and tingling. So a patient like with a stroke can have like have hemiparesia, meaning numbness and tingling on one side of their body. Paraplegia is numbness on the lower half of the body in spinal cord injured patients. Radiculopathy, disease of the nerve root, we'll talk about that. Sciatica nerve, yeah, I'm sure you've heard about sciatica nerve. You've got your sciatica nerve, which comes out of the low spine, the lumbar spine, and then goes down through each buttocks in the back. So a lot of people, if they're up walking, moving, if that starts getting inflamed and getting pinched, they can have sciatic nerve, and it's very painful. And spondylosis is a degenerative disease that can cause curvature, severe curvature sometimes of the cervical and lumbar spine. You need to be familiar with those words. Okay, so let's talk a little bit about the brain tumors. A brain tumor, also known as a neoplastic lesion. Anytime you hear this word neoplastic, that means malignancy, like a cancerous lesion. And a lesion is it's the medical word for a growth. So a lesion doesn't necessarily need to be malignant. A brain tumor doesn't necessarily need to be malignant. There's a lot of brain tumors that are non-malignant, they're benign. But all of them, you can call them a lesion, and that's throughout the entire body. That's another word you should know. So anyways, let's talk a little bit about the types of the brain tumors. I want you to focus on this chart at the top of page 2053, chart 71, the classification of the brain tumors in adults. Most of them are intracerebral tumors or lesions. Tumors and lesions are interchangeable. Most of them that are listed here that's not good news. If you have a glioblastoma, and under a glioblastoma you could have an astrocytoma, glioblastoma, an oligodendroglioblastoma, an empyoma, or a medulloblastoma. None of those are good news. And your patient will first, sometimes they might not have any symptoms, sometimes they'll start presenting with a dull aching headache. Sometimes they will all of a sudden wake up and not be able to walk, or they'll be running into walls, or they'll have vision problems. It depends on where the tumor is originating. So I do want you to know the different kinds of tumors. The tumors can also arise from the supporting structure, and that's better news. Those tumors that you see listed there, the meningioma, the neuromas, the pituitary adenomas, those are not necessarily malignant. They still need to be removed, but the difference between a benign tumor and a malignant tumor is the benign tumor doesn't have complete alteration in cells. A malignant tumor will have a complete restructuring of the cells, and it has the ability to metastasize. It has the ability to move. Malignant or benign tumors don't. Benign tumors, like a meningioma, if you were to take the cells out of a meningioma, it looks like the meninges. It looks like the same cells coming from the meninges, and it doesn't metastasize. And it's not like but you still use like radiation and stuff. You wouldn't need to do that because it doesn't tend to go into the lymph nodes or anything like that like a malignant tumor would. But when you have a benign tumor in the brain, you still have to take it out surgically. There are some developmental tumors, like I showed you, like angiomas and stuff. Those tend to not be malignant. And then some cancers that start in other parts of the body love to metastasize to the brain. Breast cancer loves to metastasize to the brain. Liver likes to go to the brain. Sometimes colon cancer likes to go to the brain. Skin cancer sometimes does. So because the brain gets quite a bit of blood flow, if you get a little piece of cancer that breaks off from a malignancy somewhere else, it tends to like to metastasize. And sometimes that's the first sign that they will find that somebody has cancer somewhere else is because it will metastasize to the brain, and then those symptoms show up, like with the headaches and things like that, and the patient goes in for a workup because of the symptoms. And then if they biopsy a piece of the tumor, which, here's another thing I need to tell you about cancer. Just because somebody has symptoms and just because a lesion or a mass is showing up on CT scan or MRI or X-ray, you don't know, you cannot say one way or the other whether that is a malignant tumor or not. You have to biopsy it. So the only way to confirm that somebody has a malignancy or a non-malignant tumor is to get a piece of that, and that's usually done under biopsy. So typically what happens is the patient will come in, they'll have symptoms, and they'll start the workup. They'll get a good history and physical, and then they'll go for, you know, an MRI, a CT scan, something like that. The mass will show up. Then sometimes, depending on where the mass is, and this is true for the entire body, sometimes they'll go in and just decide to take it out and figure out what it is once they're taking the whole thing out. Other times they'll go in and biopsy it, where they'll do like a punch biopsy or a needle aspiration, or like a laparoscopic biopsy, some way, because you need to get a piece of that tissue out. When they get the piece of the tissue out, they will send it to the pathologist. This is what pathology does. The whole area of medicine that tests tissue is pathology. So you'll send it to the pathologist. They will usually stain it. They have special staining techniques and stuff that they do. They'll look at it under a microscope, and then they can identify what kind of cells are in that tissue. Or if there are malignant cells in the tissue. So for example, if a woman is going in for a lumpectomy for a known breast cancer, then while they're in there doing the lumpectomy, they will also take out the lymph nodes around the breast, send those to the pathologist to see if there's any cancer in the lymph nodes. If there is, then the patient usually is put on chemotherapy. Another thing that they do in surgery, this is true for any time a surgeon is taking out a lesion, is they will do what's called clean margins. So they'll take out the tumor like this. Let me see if I have something I can write on. So, okay, so let's say that this thing right here, see right there, is the tumor. So the surgeon will go in and remove the tumor. So he'll go in and cut really close. He tries to get as close to it around there because you want to keep the really healthy tissue. So see, it's like that. So then they go in, and that's called excising the tumor. And this goes on in the brain as well. So they take that out. But then what they're looking for is what's called clean margins. And then what they'll do is they will send out these pieces right around the edge. See where that is? They'll send these pieces right there, right around the edge, to the pathologist, and they'll try to find out if there's cancer cells in there. And if there's not, then you can say that it had clean margins, meaning that they got all the tumor out. Some tumors, you know, you're not going to get clean margins. For example, the astrocytomas and glioblastomas, those are very spider-like kind of tumors. They go in like this, and there's no way you can get clean margins. So sometimes, especially with brain tumors, what they go in and surgically, they just try to debulk a tumor. When you debulk a tumor, you just take, like, let's say this is the tumor. To debulk it, you would just take this main section out. And you do that for a couple reasons. You're trying to buy some time for the patient. You're trying to relieve some pressure, you know, and try to reduce the intracranial pressure in the head. But you know you're not going to get clean margins. You go in knowing you're going to debulk a tumor. So those are some things to think about in your patients who have the different kinds of brain tumors. So almost all of them need surgery. There are some cases where they can't operate, like if you have an astrocytoma or glioblastoma, like back right near the brainstem, right on the optic nerve or something, and they know they can't get it out, they're probably not going to go debulk it if they know that the patient's now going to be blind for the next 3 or 4 months, because they might only have a life expectancy of 3, 4, 6 months left. Sometimes they'll go in and debulk a tumor and then radiate. Sometimes they'll radiate first to try to shrink it and then debulk it. And then if it's a metastatic thing, they'll probably give chemotherapy. If it's not metastatic, if it's primary brain tumor, they'll oftentimes try radiation as well. Really depends on where the tumor is, especially in the brain. So back to, I got off on a tangent there. Back to if they went in and did a biopsy in the brain and took out a piece of lesion, and they do that very carefully. They do that under radiographic imaging, and you can see an example of this on page 2056. They can get very, very precise, and they will do what's called a stereotactic biopsy. So they can come in from several angles, so they can exactly pinpoint where that tumor is based on MRI and CT scans and PET scans. And they'll go in, they'll take out a piece of that lesion, and then they can figure out, is this a primary brain tumor? Is it a primary astrocytoma or glioblastoma? Is it non-malignant? Is it a meningioma? Or in fact, sometimes they'll take it out and find out it's got breast cell cancer, breast cells in it. So then they know it's a metastatic breast cancer or colon cancer or liver cancer. And sometimes when they take it out, they find out, oh, this is liver cancer. Now they go in and they will do a CT scan of the liver and find out, oops, there's a mass in the liver, and now we have metastatic liver cancer rather than primary brain cancer. So that's kind of how the cancer world works. The other thing I want you to look through the localized symptoms on page 2055. You'll see that figure 71 where those are some common sites where brain tumors will show up. It's really important to understand where the tumor is and what symptoms you're going to see associated with that. So, for example, if you have a tumor in the motor cortex in the frontal lobe of the brain, the patient is very likely going to have emotional problems. They might be very apathetic all of a sudden. They could have partial seizures. They can start having some hemiparesis, numbness and tingling on one side. They could have like some bizarre language things. If your patient is starting to develop a tumor in the parietal lobe, whichever side the tumor is on, they will have loss of sensation on the other side. They may also have generalized seizures. That's pretty common with parietal lobe tumors, is to have generalized seizures. The temporal lobe seizures can also have, all of them can cause seizures. The temporal lobe can also cause some psych disorders, a lot of hallucinations, confusion, combativeness, things like that. Obviously, back in the occipital lobe, you're going to see some vision problems, diplopia, blindness, blurry vision, black in the visual field. And this is when if there's a tumor showing up back there, similar to if you have a bleed back there, is when you're going to start seeing the Hemanias hemianopsia showing up. Cerebellar tumors, this is the one, if you get a patient who has a tumor starting to grow in the cerebellum, this is when they start getting the very jerky movements or falling into walls. So that one's really obvious. If they're waking up and you know they're not, they were fine the morning before, and all of a sudden they're walking into walls and falling over, you've got a problem, probably in the cerebellar region. Okay, so make sure that you look through that. There are some imaging. There's an image on figure 72 on page 2056. That is an example of an MRI, and the white spot with the arrows on top of it, that is a tumor in the middle of the brain. One thing that you're looking for in a healthy brain is a nice midline, which his is not. The line that's going right down the brain that divides the two hemisphere on a CT scan and MRI, that should be nice and straight all the way down with nice ventricles that look a little bit like a butterfly. When the midline shifts one way to the other, you've got pressure on one side versus the other, which can compress the ventricle, and sometimes hydrocephalus, extra CSF, cerebrospinal fluid, can fill a ventricle, causing that midline to shift. So when you're looking at some of those radiographical images, that's one thing you're looking for, is a nice straight midline. Okay, We already talked about cerebral metastasis, and I think that's about it. The problem with brain tumors is it's very, very scary for families. The astrocytomas, the glioblastomas, they do not have a long life expectancy. It's very hard to treat it. So family issues become very important. These tumors tend to show up in people who are 50, 60 years old. They often have young children, kids in college. It can be very debilitating to families. So the social impact becomes important. You might need to consult pastoral care, social work, home care. Patients often want to go home and be cared for at home. And ultimately, if they have 6 months left to live, you can consult hospice so that they have comfortable care while they're dying at home. Okay, spinal cord tumors, not super common, so I'm going to kind of skip over that. Now let's talk a little bit about the degenerative disorders. Basically, Parkinson's disease is the biggest of the degenerative disorders and that you will see, and 100% you'll get tested on this, not only just in this class, but NCLEX for sure is going to ask you about this because it's pretty common. So there's the classic manifestations of pathophysiology of Parkinson's disease is they have tremors. They do a lot of this kind of tremors, but the tremors tend to occur at rest. Once they start moving, the tremors tend to go away. They have rigidity, and oftentimes it's called cogwheel rigidity. And cogwheel are those wheels that go like this, you know. And so cogwheel rigidity is like when they're going like that. So they're not really flaccid. Their movement isn't all floppy. They're very rigid. They have bradykinesia, meaning their movements are very slow, and they tend to lean forward. They shuffle their feet. Their arms hang down at their sides, and they don't really swing their arms anymore. They just kind of shuffle, and then they tend to get a mask-like appearance. The person that you will know that has this is Michael J. Fox. He is a famous actor that has Parkinson's, and if you look at him in his early career when he was doing the Back to the Future films, and then if you see him now, he can't move his face. He's got that that mask-like face, and he's got very jerky, rigid movements. So that is classic Parkinson's. What am I trying to say? Clinical manifestations. That's how it manifests itself. The problem is the pathophysiology behind Parkinson's disease is it starts in the substantia nigra of the brain, where dopamine is released, and dopamine is responsible for fluid movements and getting the impulses to all the parts of the body. Well, what happens is that there's a destruction of that substantia nigra, and the dopamine can't get to where it needs to be, which is causing all those problems. So there's not really a diagnostic test. You can't draw somebody's blood and say, oh yeah, they've got Parkinson's, but you can kind of identify it based on those clinical manifestations that I told you about, and then you try to do symptom management. But ultimately, if you put somebody on levodopa is the drug of choice for patients who have Parkinson's disease. If their symptoms improve once they're on levodopa, then you can diagnose them, yep, they definitely have Parkinson's disease. Because if they have a jerky, uncontrolled disorder, and you put them on levodopa and they don't get better, they probably don't have Parkinson's disease. So you're looking at some other motor sensory neurodegenerative disorder. The problem with putting somebody on levodopa too early is levodopa, while it's really effective, it tends to lose its effectiveness after about 1 to 2 years. So you want to not put somebody on it right away. You want to keep them off of it as long as possible so that if they can live with their symptoms and maybe do some other things to help it until the time where it gets so bad that they have to go on medication, that's the time to do it. So it gets a little bit tricky, the timing of it. But the other thing you have to be careful of in your patients who have Parkinson's, they're a high fall risk because of that shuffling gait. They have an aspiration risk because they tend to, their muscles, they lose a lot of muscle strength and muscle control in the laryngeal area. So you need to cut their food in small pieces, have them sitting up, making sure that they chew really well. They all often do this pill rolling thing too. They'll do their big pill rolling tremors that occur a lot. That's really common. So like high toilet seats, because it's hard for them to sit down and get back up. So high toilet seats, chairs with armrests on them so they can help push themselves up. Those are just some nursing implications that you would do for patients with Parkinson's. I would suggest you read the medications on table 71 for patients who have Parkinson's disease, and they are coming out with some new ones, but levodopa has been around for a long time and it's a great drug, and it just mimics that dopamine that they don't have, so it's really quite effective. Okay, there are some new surgical procedures that they're trying to do and some brain stimulations that they're trying to do for Parkinson's, but those are newer. So you probably hear a lot more about that in the next several years. He's doing quite a bit of research on it. I do want to point out, see figure 75 on the bottom of page 2066. That's how they do a stereotactic biopsy. They have to keep the head super still, so they put it almost in like a halo thing, like we were talking about last time, and then they go in really precisely. So they're going right through the brain tissue to go exactly where that tumor is. But that's a example of how they do a stereotactic biopsy, or how they go in and do like brain stimulators, like you can see here that's described on page 2066. Okay, now I want to move over to Huntington's disease, also known as Huntington's chorea. This is a neurodegenerative disease, but it's genetic. There's a genetic component to it. So, and it's autosomal recessive. So if you have two parents and they both have the gene for it, and they have a child, the chances are very likely that child is going to have Huntington's chorea. So you see it showing up in families, but oftentimes it doesn't show up until later in life, you know, like late teens, 20s, 30s. And this one is where I was telling you about with the chorea, they start, you know, having really jerky movements, and pretty soon it impairs their ability to drive, it impairs their ability to walk. Ultimately, it's fatal, and towards the end of their life, they end up having to be in wheelchairs. So genetic counseling is really important for patients that may have this, especially if they're thinking about having their own children. The other spouse might want to get tested and then make some decisions about what they want to do. The next thing I wanted to talk about is amyotrophic lateral sclerosis, also known as ALS, also known as Lou Gehrig's disease. Lou Gehrig was a very famous baseball player many years ago, he's passed away now, who developed Lou Gehrig's disease. And the person that you'll know now that has this is Stephen Hawking, perhaps the most brilliant mind that has ever existed since Albert Einstein. Google him. Google Stephen Hawking and just watch his story. It's absolutely amazing. But he has ALS. The problem with ALS, it's very similar to Guillain-Barré, like we talked about last time in chapter 69, where it is a neurodegenerative disease. It starts in the feet and tends to move up. The problem is it never reverses. It just gets worse. So it is always fatal. The patients have to eventually be on a respirator because they can't breathe. It shuts down their effort to breathe, so they end up having to be on home ventilators. They need help feeding. They're often on feeding tubes, and it's a horrible disease because nothing changes with their cognition. They don't get dementia. They aren't confused. They are just locked in and they can't move, and it's absolutely horrible for both them and their family. So a lot of social support, in addition to making sure their skin is intact, making sure they're getting good nutrition. They're up and, you know, get them up to a wheelchair, try to get them as social as possible. But that's a horrible disease, ALS. Muscular dystrophies, I'm on page 2072 now. Usually a genetic disorder. Children are born with this. There's whole organizations now for helping kids who are born with muscular dystrophies. Those are the kids that need braces on their legs or they walk with walkers. And so the primary nursing goal here is get them the physical support they need. Do they need walkers or braces or special devices at home? Get them in touch with physical therapy, occupational therapy. You know, does the family need some support at home? Is the car going to need to be adapted so they can get in and out of the car? Do they need ramps put up at home? So there's a lot of implications for people who are living with permanent and long-term physical disabilities. Degenerative disc disease, for the next couple sections, from page 2073 pretty much to the end of the chapter, I think, yeah, pretty much, is talking about degenerative disc disease. Really common. A ton of people in the United States have disc problems, and it can happen in the cervical, the thoracic, or the lumbar discs. And there's a great picture of it on page 2074, figure 77. And basically, you have a disc in between the vertebrae, and it's kind of like the same stuff that's under your knee, like the cushion in your knee, and there's a lot of joints that have that. It's like a cushion, so the bone, you don't have bone on bone. Well, sometimes that cushion wears down, or there's pressure on there. Sometimes people have tweaked their back, they've fallen, or they've been in an accident or something, and those discs can either herniate, means pops out onto some of the spinal roots that come out there. They can rupture altogether, and then what happens is you get bone on bone and you get pressure on those nerve roots, which is extremely painful. So the NSAIDs are helpful here. Bed rest is helpful. You try to get the patient to a place where they don't have to have it surgically repaired, but if it's bad enough, then they go in and have to have a laminectomy, meaning the disc is repaired, or sometimes they have to fuse the vertebrae together if so the discs aren't pounding, or the vertebrae is not pounding on each other. So that's often what's done for these after the NSAIDs, the physical therapy, the bed rest, and not doing, like, for example, if it's caused by a horseback rider who's constantly pounding, or a runner who's constantly pounding. If they stop that, sometimes the disc will repair. Like if it's just an inflammatory process, it can stop if you can get the person to stop the behavior that's causing the irritation to the disc. But if not, then they have to go in and do laminectomy, herniectomy, disc repair of some kind. They have to have surgical repairs. That's pretty much all you need to know, because the rest of the chapter just talks about what happens if the disc herniates in the cervical area, or if it herniates in the thoracic area. It's kind of like a spinal cord injured patient. It depends on which disc is herniating, where the symptoms, because like if you've got a problem with your disc up here, in the cervical region, you're going to see some problems like numbness and tingling in the shoulders and arms. If it's further down in the thoracic or lumbar region, you're going to have symptoms, more down in your thoracic and abdomen area, or numbness and tingling going down one leg. So the location of the disc problem will have clinical manifestations associated with wherever the disc is. So, okay, that's it. Ta-da, we're done. We've done neuro stuff. I love neuro stuff, but it is complicated. So, okay, so that's it. Call me if you need me. Okay.